Thank you very much. Hi, everyone. I would like to talk about the microablation in breast lesion from established fibroadenoma treatment to emerging oncologic potential. My agenda is the introduction to the fibroadenoma, definition of fibroadenoma and its prevalence, characteristics, significance, benefits of thermal ablation of fibroadenoma, and comparing thermal ablation to surgical excision, and types of thermal ablation techniques, patient selection criteria, effectiveness of thermal ablation for fibroadenoma, and last one, the emerging oncologic potential of thermal ablation. As you know, breast fibroadenoma is commonly seen among women worldwide, with incidence having increased over the past few decades. The breast cancer screening and some improvement in diagnosis have increased the detection of rate of the fibroadenomas. Breast fibroadenomas histologically rises due to the proliferation of ductal or lobular tissue with an overall incidence of about 2.2%. They account for 68% of all breast masses and 44 to 94% of biopsied breast lesions. Small asymptomatic breast lesions generally do not require treatment, and some surgeons tend to favor conservative management of breast fibroadenoma with regular follow-up, which should be accompanied by auxiliary examination every 3 to 6 months in order to monitor the status of breast lesion dynamically. However, some patients with large-sized breast fibroadenomas suffering from the pain or anxiety are not satisfied with a conservative management approach and seek treatment. Thus, it's necessary to excise part of the breast fibroadenoma according to therapeutic options that depend on different presenting situation. The main management of these benign tumors is serial observation or surgical resection. The most of benign tumors are managed with serial observation, but several patients will develop anxiety due to local discomfort and worry about cancerous potential. Surgical resection is the most effective treatment option for patients suffering from the breast lesion, although it's an invasive procedure. The patients much prefer a better cosmetic outcome and fewer surgically associated complications, which are commonly associated with minimal invasive procedure. Over the past few years, the introduction of vacuum-assisted breast biopsy system has proven to be a valuable innovation in managing breast fibroadenoma, and the method is also considered minimally invasive, well tolerated, and has better cosmetic outcome than does traditional open surgery. The common methods for the tumor resection are conventional surgery, vacuum or endoscopic assisted minimal invasive surgery. However, these therapeutic methods may cause the unnecessary excision of normal tissue and result in a scar or unsatisfied cosmesis. Conventional excision is safe and effective for managing fibroadenomas. However, for large fibroadenomas, obvious scar due to extended incision or misshapen breast resulting from the collapsing cavity may impose psychological burdens on patients with cosmetic expectations. The alternative techniques are rapidly developing and aim to achieve a balance of therapeutic efficiency and cosmetic satisfaction. One of the most representative strategies, vacuum-assisted biopsy, has been extensively used in the minimally invasive management of fibroadenomas. However, current consensus recommendations state that only less than 7 centimeter cube fibroadenomas should be managed with vacuum-assisted biopsy for fibroadenomas. Moreover, a large number of studies reported that both regular residuals and significant complications are observed in vacuum-assisted biopsy of 2 centimeter fibroadenoma, again suggesting that it may not be suitable for the treatment of 2 centimeter fibroadenomas. Advantage of the thermal ablation over the vacuum-assisted biopsy system include simultaneous treatment of multiple tumors, a shorter treatment time, and no tumor size limitation. Minimally invasive thermal ablation technique include cryoablation, radiofrequency ablation, microwave ablation, high-intensity focused ultrasound, and laser ablation are becoming a robust option for the treatment of fibroadenomas. I would like to first talk about the radiofrequency ablation thermal techniques. In RFA, alternating the current from the high-frequency generator flows between electrodes placed in the lesion. This current incites ionic agitation, causing intercellular ions to move in response to an alternating current and generate frictional heat with further damage to integrity of the cell membrane, protein denaturation, and nuclear disruption that ultimately result in cell destruction. Cell death usually occur at temperatures higher than 60 Celsius degree, with shorter exposure time required as the target temperature increases. Advantage of RFA include its minimal invasive nature, tolerability, better cosmesis with almost no scar, and its applicability to patients who refuse to undergo or are not candidates for surgery. The main disadvantages of RFA are the lack of the intra-procedural monitoring of the limit of ablation zone and the necessity of placement of ground pad on the patient. The procedure risks are mainly similar to those of cryoablation and include bleeding, infection, skin or chest wall injury, and incomplete treatment. The risk of ground pad burns is unique to RFA. What about the cryoablation? Cryoablation exerts its effects directly through cold-induced cellular injury and indirectly by damaging the microvasculature, resulting in tissue ischemia. The result is the coagulative necrosis of tissue within the lethal isotherm threshold, which is approximately 5 millimeters within the visible ice margin at ultrasonography. The advantage of cryoablation include its minimally invasive nature, tolerable pain labeled during and after the procedure, good cosmesis, short duration and recovery time, and its applicability to patients who refuse or are not candidates for surgery. What about the HIFU? HIFU is a technique that uses converts high-frequency ultrasound waves to destroy the tumor tissue at the focus point of the beams. Several mechanisms have been described for HIFU ablation, including hyperthermia, acoustic cavitation, microstreaming, and immune system modulation. The thermal injury results from the absorption of energy from focusing the ultrasound waves on target and maintenance of the focal temperature of 56 to 90 Celsius more than 1 second. Focal high temperature in tissue result in coagulation necrosis and the cell death. HIFU causes minimal pain, resulting in the less requirement of anesthesia and making this modality a suitable choice for patients who are not candidates for surgery. HIFU is non-invasive and requires no incision. Therefore, it results in better cosmesis and lower risk of infection and can be offered to appropriately selected patients who refuse surgery. What about laser therapy? The goal of laser therapy is elective thermal destruction of abnormal tissue while sparing normal tissue. At the laser tissue interface, the tissue absorbs photons, causing excitation and release the thermal energy that result in a rapid increase in temperature and irreversible damage to the tissue. The last one, the microwave ablation. Similar to RFA, microwave function by creating frictional heat to cause coagulative necrosis. However, unlike RFA, which functions with the use resistive heating, microwave ablation works through the heating tissue surrounding an antenna that couples energy from a power source to tissue. This is accomplished by means of dielectric Hysteresis, which is polar molecules, predominantly water in tissue, are forced to align and continuously realign with an oscillating electric field, which increases their kinetic energy and therefore increases the temperature. The lethal temperatures are accomplished at a frequency of 900 to 2500 megahertz. Because microwave ablation is less effective in low tissues such as adipose tissue, tumor cells are thought to be preferential destroyed instead of normal fatty breast tissue. The effectiveness of microwave ablation for tumors in dense breast tissue has not been described specifically. The energy delivery in microwave ablation is less limited by the electrical impedance of tissue when compared with RFA, and therefore it theoretically offers a great chance for complete ablation. Among these percutaneous ablation procedures, microwave ablation has a higher thermal efficiency because of large coagulation volume, more homogeneous shape of coagulation zone, and a higher intratumor temperatures than with radiofrequency ablation, which is the most popular ablation technique. What is the patient selection criteria for thermal ablation of fibroadenoma? First, a diagnosis of fibroadenoma according to pathology confirmation from a biopsy. Ineligibility for surgical resection due to comorbidities or refusal to undergo surgery because of cosmetic concerns. The patient with tumor-related symptoms, including pain, nipple discharge, and discomfort, or evident psychological pressure due to the risk of developing breast cancer. The patient refusal to accept other treatment as a result of patient physical condition or cosmetic consideration. And the last one, the Berat score of the 4, but with biopsy-proven benign results. What is the thermal contraindication for thermal ablation for fibroadenoma? Patient with coagulopathy or severe cardiopulmonary or renal diseases, patient with acute or active infection, ongoing pregnancy, lactation, or menstruation. What about the treatment effectiveness? The ultrasound-guided microwave ablation has been proven to conformally ablate lesion without normal tissue injury and thus provides an alternative treatment modality. In the literature, no obvious scar or breast deformation was observed in ablation of fibroadenomas larger than 2 centimeters, suggesting that the superiority of microwave ablation in improving cosmesis remains even for fibroadenomas larger than 2 centimeters. Ultrasound-guided microwave ablation is a satisfactory method to treat large fibroadenomas in patients with concern or anxiety regarding post-operative recovery and cosmetic effects. The reported 2-month volume reduction rate for fibroadenomas is the diameter for fibroadenomas 1 to 2 centimeters. The volume reduction rate 85% to 98%, larger than 2 centimeters, volume reduction rate 80% to 97%, larger than 3 centimeters, volume reduction rate is average 83%. As a conclusion, ultrasound-guided percutaneous microwave ablation has proved to be a promising treatment for fibroadenomas. It not only achieves satisfactory effect without damage to normal tissue, but also produced significant shrinkage of ablated fibroadenomas with adequate breast appearance. Ultrasound-guided percutaneous ablation is a safe, effective, feasible technique for minimally invasive treatment of fibroadenomas with good cosmetic outcomes, even with large and high-risk tumors. It can be mastered easily, and skilled interventional radiologists show the rapid improvement in mastering the technique. I would like to talk about our results. The early results of the ongoing study we initiated in our clinic in September 2025. The percutaneous microwave ablation was performed on fibroadenomas histopathologically confirmed by percutaneous true-cut biopsy. All patients underwent dynamic MRI with ID contrast before the microwave ablation procedure. 1 month after the microwave ablation procedure, dynamic MRI with contrast material was performed to check for residual. All patients also underwent ultrasound 1 and 3 months after the percutaneous microwave ablation to calculate the volume reduction rate. Follow-up is planned for 6, 9, and 12 months. I would like our case, the case 1, 61-year-old female, the history of left mastectomy due to invasive ductal carcinoma. Ultrasound showed nearly 2 centimeter virus 3 category lesion in the right breast at the 3 o'clock position consistent with fibroadenoma. This lesion was proved to be a fibroadenoma by core needle biopsy. The patient refused a second surgery and preferred the percutaneous thermoablation technique as the treatment. The ultrasound appearance, the fibroadenoma, the largest diameter, nearly 2 centimeters. I'll show you case 1 video. As you can see here, the fibroadenoma and the hydrodissection process. We generally use the 5% of dextrose or Voluven around the lesion. The hydrodissection process is the most important, more critical step for procedure of thermal ablation of fibroadenoma. Yeah. The longest diameter of we start the thermoablation process. We use the pulled out technique. And the postoperative ultrasound control, immediately after postoperative ultrasound control, the lesion was totally ablated. And the second case, a 53-year-old female, the history of right mastectomy due to invasive ductal carcinoma, and nearly 2 centimeter virus 4A category lesion was detected on breast ultrasound at the 12 o'clock position. The lesion was biopsied and found consistent with fibroadenoma. You can see here the fibroadenoma or no vascularization with color Doppler ultrasound. And the thermal ablation process. Before the ablation, you can see here the longest size of the fibroadenoma. In Doppler ultrasound, no vascularity. First, after the hydrodissection process and the thermal ablation. After the ablation, the control ultrasonography showed us the complete ablation zone. Yeah. Lastly, I'd like to talk about the thermal ablation of malign breast lesion. Regarding the efficacy, therapeutic uses, and the complication of percutaneous thermal ablation for malignant breast lesion, a current and valuable meta-analysis and phase 2 study were available in the literature. First one is the meta-analysis. According to this meta-analysis, studies were included if the treatment success was reported as completed ablation on imaging and or histology. At least 10 patients with tumors less than 2 centimeters on pretreatment imaging were treated per ablation method. The thermal ablation with either microwave, RFA, cryoablation, HIFU, or laser ablation was performed. Only the result from a tumor less than 2 centimeters were included in this meta-analysis. 176 publications were checked for eligibility, and eventually 37 studies were included. One study report on percutaneous microwave ablation, 2 on HIFU, 5 on laser ablation, 8 on cryoablation, and 22 on RFA. Cryoablation, laser ablation, and HIFU were almost exclusively performed under local anesthesia, whereas RFA and microwave ablation were mainly performed under general anesthesia. MR guidance was always used for HIFU ablation and one in cryoablation study. All other procedures were performed under ultrasound guidance with the exception of 2 laser ablation studies. According to the meta-analysis, complete ablation rates for RFA 92%, microwave ablation 87%, cryoablation 77%, HIFU nearly 62%, laser ablation nearly 69%, overall ablation rate 86%. What about complication according to this meta-analysis? For RFA, the most severe complication was the case of chronic granulomatous mastitis and one pneumothorax owing to probe misplacement. Microwave ablation, 1 epidermal skin burn and 2 slight thermal injuries to the pectoralis major muscle were found after a microwave ablation in the resected specimen. No other severe adverse events occurred. The complication for cryoablation, only 2 studies reported complication associated with low temperature of cryoablation. In these cases, the tumor was located within 2 centimeters of the skin surface. The other reported complication included self-limiting ecchymosis, seroma, nodular thickening, and hematoma or swelling at the cryoablation. The most severe complication was an arterial bleed after the removal of cryoprobe. Overall, 14 complications in 283 patients were reported after cryoablation. Complication for HIFU, no adverse event occurred in one study and 6 occurred in the other. These 6 complications include pain, skin burn, and shoulder pain. Complication of laser ablation, according to this meta-analysis, the most severe complication was pneumothorax, which occurred in a tumor close to the thoracic wall. The other reported complications were a palpable lump, skin or fat necrosis, hematoma, seroma, erythema, skin burns, or pain. Overall complication occurred in 20 out of 165 patients. Overall complication for RFA, microwave, cryoablation, HIFU, laser, complication rates varied from 5 to 18% between techniques. Complication rates were highest after HIFU ablation and lowest after cryoablation. Based on according to this meta-analysis, based on the complete ablation rates reported in this review, RFA, microwave ablation, and cryoablation and are most promising techniques. A formal recommendation or the best technique is not possible because of large heterogeneity in the included studies. These meta-analyses demonstrated that thermal ablation techniques treat small-sized breast cancer are safe, using local anesthesia is feasible, and overall complete rates are high, especially RFA, microwave, and cryoablation are promising techniques as an alternative to surgical resection without jeopardizing current treatment effectiveness of safety. Thermal ablation technique can potentially reduce treatment burden and morbidity and improve cosmetic outcome in patients with early stage breast cancer. The recently published in radiology, this study is PAS-2 trial. This study is open label. PAS-2 picked the winner trial. The postmenopausal women with unilateral luminal T1 and 0M0 breast cancer were included consecutively. After providing informed consent, patient underwent MRI to confirm the presence of a tumor 2 centimeter or smaller. 50 patients provide informed consent, and 41 of whom were randomized and underwent percutaneous ablation. In this study, the treat and resect studies in patients with early stage breast cancer have reported complete rates of 80% to 92% for radiofrequency ablation, microwave ablation, and cryoablation. In conclusion, cryoablation is the preferred technique for comparison with surgery in a future PAS-3 trial. Thank you very much.
Thank you so much, Dr. Berat, for your excellent and insightful sharing. Have a rest now. Now let's welcome to our second speaker, Dr. Ahmed Hassan Soliman. Professor, please.
Yeah. Can you hear me?
Yes, we can hear you clearly. Yes, please.
Thanks, Dr. Berat, for the nice presentation. And thanks for Canyon International Microwave for the invitation and guesting me. So
It's our pleasure.
okay. So a lot of things is going to be common between the two presentations. Okay. Microwave ablation and breast lesions from established fibroadenoma treatment to emerging oncological potential. Just a sec. So these are our objectives: traditional treatment of fibroadenoma, what's thermal ablation, discuss patient selection, procedure planning, and post-ablation care, risk and complications, some cases, follow-up, what's in the future, and conclusion. So the traditional treatment of fibroadenoma includes traditional surgery. However, it's focused on excision, but carries high risks of visible scarring, structural alteration, and patient's anxiety.
Excuse me, Dr. Ahmed, can you share your presentation, please? We cannot see it.
Okay, I'm sorry.
I can see it. I think it might be a connection problem. I can see it.
Yes, I can see it also.
Okay. While regarding microwave, it's minimally invasive. It's just a pinpoint accuracy, achieving eradication with a pinpoint thermal precision, eliminating visible scars and minimizing psychological trauma. We can almost see how scars can look like, even with high aesthetic outcome. However, that's how a pinpoint prick of a microwave needle can look like. So fibroadenomas we can just watch it and monitor it. However, a lot of patients just having a palpable lump and carcinophobia during frequent or regular breast ultrasound examinations can ends up in dissatisfaction and aiming to remove it. Surgical excision, that's the second option, and that's mainly for giant ones, more than 3 centimeters, and in some papers, more than 5 centimeters, or according to the tumor size, breast size ratio. And in others, we can also use cryoablation. What is thermal ablation? Usually, the antenna generates electromagnetic field, high frequency electromagnetic field through non-insulated tip that cause oscillation of water molecules, ending in frequent friction. Movement generates heating up to 80 to 100 degrees Celsius, and it ends in cytotoxic effect, coagulative necrosis, and cell death. However, if more than 100 degrees centigrade, it can end in carbonization with tissue charring, which we doesn't like in most of the ablation techniques, especially in thyroids and in breast. The ideal temperature to which we ablate breast lesions is from 35 to 40 degrees centigrade. So that's the traditional liver specimen where we can see different ablation zones, where in the blackish one, it ends in carbonization, followed by a whitish one, followed by a reddish one, to see the different ablation zones with the safety margin. Comparable to microwave, that's a small comparison, where thermal capacity achieve higher temperature in microwave, larger ablation zone in microwave, and less time compared to RFA. Also, optimal heating in cystic and hypervascular structures, no heat sink effect, and significantly less pain, no ionic current passes through patient's body, and doesn't need ground padding, so it's safe with pacemakers, pregnancy, and joint prostheses and implants. Usually, the microwave generator produce power by max core technology, which aids in precise and stable output, also available in continuous and pulsed modes. We can see the tip having the ceramic tip, ensuring consistent spherical ablation zone with high echogenicity on superior ultrasound, aiding superior ultrasound visibility. It also has a internal cool tip antenna and available in different gauges, varying from 19 gauge to 15 gauge. We have more than one needle type from the canyon. One is the sphere type, sure, and thigh type. The thigh one are the one we use in the breast ablations. So we're gonna move for patient selection, procedure planning, and post-ablation care. Who's our patient? A patient who is high risk, as the one Dr. Berat mentioned, elderly patient having comorbidities, unfit for surgery, or refusing traditional surgery. Another patient who is aesthetic conscious, patient who is highly scar phobic and actively refusing surgery to avoid obvious visible breast scars. And carcinophobic patients, highly anxious patients with positive family history, demanding every 6-month follow-up, requiring definitive, rapid solution for ease panic. So during the ablation technique, if we're dealing with a benign lesion, usually we do it as thyroids ablation in a moving shot technique where we shift the microwave antenna from deep to superficial and from cranial to caudal, as Dr. Berat mentioned in his video. While if we're dealing with a malignant lesion, it's usually a T1 lesion, and we deal with it in a stationary fashion of ablation as we do in liver tumors. In order to do a procedure pathway, we must first position the patient and optimize our access point to our target. If we're dealing with a benign pathology, we usually perform a 3D volume in order to have a baseline lump volume in order to follow it in the future and see the degree of volume reduction. Sterilizing the patient in order to make everything aseptic. Anesthesia, local infiltration of hydrodissecting fluid cocktail. And we start ablation according to whether it's a benign or a malignant lesion. If we're dealing with benign lesions, it's already established in fibroadenomas, which is the most common thing we use in practice. Most papers showed a volume reduction reaching 85%, lesion disappearance in 53%, and the efficiency rate for ablation was 99%. And that's the technique of the moving shot, where we do from deep to superficial and from medial to lateral or lateral to medial, according to the breast, which side. If it's the right one or the left one, it's going to be different. And that's a video demonstrating the hydrodissection technique. That's a large fibroadenoma where we inject the hydrodissecting fluid cocktail superficial and deep, isolating the target from the overlying skin and from the underlying pectoralis. And then we put the antenna of the microwave needle as inferior caudal as possible, and from deep to superficial, from deep to superficial, from deep to superficial, until the whole lesion become echogenic with dispersion of the air foci resulting from the ablation process. Fibroadenomas is characterized mainly by very high water content that ends it to shrink on table immediately after the procedure with like more than 30% immediate volume reduction. That's another case that was having a volume of 4 ml, and that's demonstration for the ablation technique, again, from deep to superficial, and from medial to lateral or lateral to medial, until the whole fibroadenoma become dispersed with the air foci of the microwave ablation procedure. The initial volume was 4 ml, and after the procedure, we're gonna wait to see how much did it shrink. During the procedure, we always try not to ablate the nearby breast tissue, normal breast tissue, in order the patient won't feel lumps or bumps of fat necrosis, which is a little bit annoying for the patient. And you can see during the procedure, the fibroadenoma become a little bit superficial near the skin. So another needle entered to inject again hydrodissecting fluid to isolate it from the overlying fluid, from the overlying skin. And that's the volume for a fibroadenoma. And immediately afterwards, it was 21 volume. And immediately after the procedure, it became a 14 ml. Another one, it was 4 ml, and immediately after, it was 1.7 ml. And that's the one we were just mentioning in the video. And the third one of 4.9 ml, and immediately after, it was 2.8 ml. Another one that was 1 ml, and immediately after the procedure, it was 0.36 ml. That's a giant one that was ablated, and on 6-month follow-up, the lesion jumped up, decreased up to 86% volume reduction, and it was documented in this paper by Chinese group in 2021. So that's the established thing regarding the breast fibroadenomas and cysts. And what's the emerging thing regarding malignant lesions? So everyone think when I'm going to manage a malignancy that I'm going to ablate in this gentle young lady who is afraid of the aesthetic outcome, but actually this old lady is the one who is candidate for breast ablation nowadays, and is supposed to be the one who is candidate for microwave ablation, not the young lady. So what's nice regarding the malignancy and why is it going to be emerging? Number one is raising all breast awareness campaigns, and that's the biggest awareness campaign in my country. It's called Bahia Hospital. And from where did the idea come, and when and why we're looking for minimally invasive techniques? All of us know about the morbidity of axillary lymph node dissection as illustrated in the picture. And with the evolution of nodal surgery for breast cancer, de-escalation from axillary dissection to sentinel lymph node to nowadays a lot of papers talking about no more nodal surgery for cases that is early detected. In the 1970s, there was a question between, is modified radical mastectomy equivalent to radical mastectomy? And the answer was yes. And between 76 and 1984, was breast conservation local control equivalent to mastectomy? And publishment noted the answer was another yes. And in between 1999 and 2004, does sentinel lymph node biopsy accurately assess and stage the axilla? And the answer also was yes. And in the Alamang trial, in between 1999 and 2003, does sentinel lymph node have less morbidity than axillary lymph node dissection? And the answer was yes. And in the Z11 trial, between 1999 and 2004, can patients with clinically negative axilla and 1 or 2 positive lymph nodes avoid axillary lymph node dissection? And the answer was yes. And in the Amarus trial, can radiation replace axillary lymph node dissection for positive lymph nodes? And the answer was yes. And nowadays, we're talking about the most well-known trial called Sound Trial 21, which was talking about can we omit opening the axilla, and the finding was patient with breast cancer having a lesion less than or 2 centimeter and a negative result axilla on preoperative axillary lymph node ultrasonography can safely be spared of any axillary surgery whenever the lack of pathological information that does not affect the postoperative treatment plan. From this point, a patient coming with early detection, having a lump less than 2 centimeter, and at the same time, negative axilla, this is the era where minimally invasive technologies can emerge. So, patient autonomy, we're going to deeply respect the psychological burden of scourge and carcinophobia. And at the same time, that's the pillar of the early detection. And that's the de-escalation surgical harm regarding the axilla. With the emerging of the microwave technology, I think the coming future is going to make us see a lot of cases, and it's going to be mentioned in the future treatment plan algorithms. So the result is that interventional radiology can no longer feel helpless when treating medically unfit or patient that is surgically carcinophobic. That's a lot of publications. Most of them is related to minimally invasive techniques in management of breast cancer with systemic reviews and meta-analysis showing overall success in treatment, reaching technical efficiency around 75%, and minor complications 6 to 8%. Who's our patients? Patient refusing with a T1N0M0, or patient with limited node disease, patient who is unfit for surgery, patient that we want to manage local control with stable metastasis, unresectable chest wall recurrence post-mastectomy, unresectable breast recurrence post-breast conservative surgery. What's the complication that we can face during microwave ablation? The common side effect is pain and discomfort. That's the most common ones. Also, swelling and redness. Frequent fluid accumulation in the treated area is a normal inflammatory response. Some bruising and skin discoloration. However, other are rare side effects, skin burns or muscle burns. That's why we continuously like to infuse hydrodissecting fluid during the ablation procedure. And the optimal lesion size is between mainly less than 2 centimeters. However, a couple of cases we did between 2 and 3 centimeters. Also, fat necrosis that makes bumpy skin sensation is a common side effect. How can we assess or follow up the patient? If we're talking about benign lesions, we just follow up the size in a 3D fashion with volume illustration, where if we're talking about malignancy, so we ask the patient to have a mix between ultrasound, follow up regarding the size, and at the same time, we have to do MRI or contrast-based study scan like contrast-enhanced sonomammography to assess both size shrinkage and at the same time assess the vascularity, and we can do it after 1 month, 3 months, 6 months, and 12 months. Most of papers mentioned volume reduction reaching 85% after 1 year, and treatment efficacy in benign lesions reaching 99%. And these are the primary tools for following up the patient, whether ultrasound, contrast-based study, and clinical examination. So to conclude, before having a couple of cases, offer patient honestly different surgical and interventional modalities as well as observational option, case by case. Respect the patient's fear and phobic manner even for benign lumps. Respect the patient's will not to have obvious breast scars. Early breast cancer detection is the cornerstone for having the option of minimally invasive treatment options. Understanding the technology of microwaves and techniques of ablation is mandatory. De-escalation of the axillary management up to omitting opening the axilla gave IR promises in future approved role in breast cancer management algorithms. No more feeling helpless for treating patients who are unfit, like elderly or having comorbidities, or patients who are refusing surgeries because of panic or surgical phobia. Post-operative care instruction adherence. Contrast-based imaging modality are mandatory for follow-up of malignant cases. And thanks regarding that's the part. I'm gonna show you 1 or 2 cases for malignancy. Just a sec. Cases.
Everybody, just wait for a few minutes. And Dr. Soliman is looking for the cases. Hey, Dr. Soliman? Are you going to show us some cases?
Yes. Yeah, just a sec. I just something regarding the internet. Just a sec. It's
Okay.
case cases regarding
Take your
malignancy.
time. Yes, no worries. If you have any questions, you can type in the chat box. And after these presentations, Dr. Berat and Dr. Soliman will answer these questions for you. Let's wait for a few minutes. Yeah, Dr. Henry is giving questions. Anybody else? We can use this time.
I think the question is the use of the power. Normally, we use the power 20 watt, and then the fibroadenoma is vascular reach with color Doppler ultrasound. We generally use 30 watt.
Mhm. Okay, Dr. Berat has answered the question. And also,
I think question about the power.
Yeah.
Yeah.
And how about the time?
Routinely, we use the 20 watt.
20 watt.
Yeah,
And,
yeah. The vascular lesion with color Doppler with 30 watt. The vascular lesion, the vascular reach lesion. Yeah.
And regularly, how much time we will set?
We use the moonshot technique.
Moving shot technique. How about the circle?
Yeah,
Like 10 seconds? Or like 5 to 10 seconds moving as a circle?
Procedure time, the procedure time, skin to skin, the roughly 20 minutes.
Okay. I see. And also we got a lot of questions from Dr. Ahmed in the early time. And which ablation method Dr. Berat are cool using, and what is the antenna specifications?
Yeah, we use the 18 gauge, 7 centimeters, and we use antenna.
Okay. Thank you for your answer. And Dr. Soliman, are you ready?
Yeah.
Okay, please. We will answer all questions later for the rest of questions.
Can you see? Okay. Can you see this?
We can see
this screen is, yeah.
It's getting stuck.
Okay. It's just loading. Okay. Can you see a mammography film right now?
Yes, we can see it.
Okay, perfect. So that's a mammography film showing a lesion that is having indistinct outline related to the breast upper outer quadrant. And that's how it did look like on ultrasound. It was a mix between solid and cystic components with areas of breaking down, and it was having avid vascularity on Doppler. Biopsy was proven to be invasive ductal carcinoma grade 3 and luminal A, ER, PR positive, and HER2 negative. And then after ablation of the lesion, and we did a contrast mammography for this patient. And then after ablation of the lesion with 6 months, the lesion totally disappeared with a negative contrast uptake on contrast mammography. And we can see on the ultrasound the indistinct outline and the haziness of fat necrosis related to the site of the lump ablation. Another lesion, it was a early detection T1 lesion. Also, it was proven to be invasive ductal carcinoma by biopsy that showed contrast uptake on contrast enhanced sonomammography. And we just after ablation, we followed up the lesion by ultrasound, where we can see the zone of the fat necrosis related to the lesion ablation with a safety margin, making the surrounding breast tissue indistinct, which is different from what we do in the benign breast lumps. While on the follow-up contrast mammography, we can see still having a rim of contrast uptake related to the margins, the inferior and central margin, which could be resultant still inflammatory response, or could be a residual pathology, which will need to be followed up again after 3 months to accurately decide. And there was a controversy whether to biopsy the lesion or just wait and see. And we decided to wait and see for a second follow-up, and we're still going to show the results if we're going to have any in the next meeting, hopefully. And that's the last case, where also we can see a lump that was ablated. However, after ablating the lump, still we can see a marginal contrast uptake, which I think is also attributed to peripheral hyperemia rather than residual tumor, and also is going to be followed up in the next event. We're still having a learning curve to show up these cases. And a final case where it was ablated, and we can see the ablation zone and the fat necrosis surround and indistinct margins. And also on follow-ups, we can see the periphery having distinct margins where the center is radiolucent, keeping with fat necrosis. And we didn't have a contrast-based study yet to assess whether this is a residual lesion or it's just or it's just part of the healing process of the ablation, because we didn't do that much cases in malignant pathologies. These were just the cases that I wanted to show regarding malignant cases ablation. Hello? Can you hear me?
Yes,
Hi.
we can hear you.
Okay. Yes.
Thank you so much, Dr. Berat and Dr. Soliman. Thank you both for such wonderful presentations. Let's move to question and ask session. And let's answer these questions. And Dr. Berat has already answered 2 questions.
Okay.
Yeah. Let's come to the third question. Question to Dr. Berat as well, regarding the conservative procedure of leaving the. Yeah. Dr. Berat, please.
Yeah, I couldn't hear. Please repeat again.
Okay. Did you see my screen?
Yeah.
Okay. The third question, regarding the conservative procedure of leaving the fibroadenoma with 3 to 6 months mammography scanning follow-up. Wouldn't so much frequent X-ray scanning add to the hazards of radiation? Wouldn't it be better to remove by microwave ablation or return to normal a new follow-up protocol?
Yeah. Before the procedure, we performed the contrast enhanced MRI. After the procedure, the 1 month after the procedure, we performed contrast enhanced MRI again for the residual lesion or residual tumor, and then after that, the 1 month, 3 months, 6 and 12 months for follow-up for volume reduction rate.
Okay.
Can I translate the question to the Dr. Berat if possible in Turkish?
Sure, please.
Hocam aslında burada şeyi soruyor. Bir fibroadenoma olan birine follow-up ederken tekrar mamografi alıp follow-up'ta yapacağımıza önce mikrodalgayı yapsak, o kadar radyasyona boğmasak hastayı da ondan sonra follow-up yapsak nasıl olur diye bir soru aslında bu.
Yeah, but I understand. The mammography is the essential for the screening of breast lesion or breast screening. The mammography is essential. But the follow-up of the fibroadenoma is the ultrasound, with ultrasound, the only ultrasound.
Okay. Is it clear? Let's move to the fourth question. For malignant breast lesion with less than or equal to 2 centimeter, how you confirm the free margin? Yeah, maybe Dr. Soliman, please help us to answer the question.
It's mainly based on the contrast study, and up till now, lesions with having peripheral contrast uptake, we are still building up an experience to see whether we should biopsy it or just wait and see for a next contrast-based study 2 months later, so to have a free time between the initial ablation and the third follow-up after 3 months from the initial ablation procedure. So it's either to biopsy the periphery or to follow up, have a second follow-up and take an action accordingly.
Okay, understand. Then let's move to the fifth question. Do you use vacuum assisted excisions?
Yeah.
Do you use vacuum assisted excision?
Yeah, I use it a lot in benign lesions, by B3 lesions, but I don't like to use it in giant fibroadenomas and in vascular fibroadenomas because the procedure is extremely bloody and have a lot of bleeding during the procedure. I think microwave is better in larger size fibroadenomas and in vascular fibroadenomas. Also, another thing very important is the ratio of the breast of the lump of the fibroadenoma in comparison to the breast size. So we can ablate a large fibroadenoma if we're having a big size breast like cup C or D, but if it's in a small size breast like cup A, I don't think it's wise to excise it using the vacuum, either to go for surgery or to ablate it and follow it up.
Okay, it's really very clear.
Yeah.
Okay.
I do not routinely the vacuum assisted biopsy in the daily practice. In my opinion, the microwave ablation or any thermal ablation techniques, the results of any thermal ablation technique is better than the vacuum assisted biopsy.
Yes, agreed. Okay, thank you. This is all questions for today. And thank you again to Dr. Berat and Dr. Soliman. And thank you for all your active participation. Please stay tuned for more academic activities from IMAA and Canyon Medical. Have a great day. See you next time.